morning, everyone. My name is Maya Luria with TMC for Seniors, and this is the start of our Women's Health Month. I want to introduce you to Samantha Johnson. She is a physical therapist with our TMC Adult Therapies, and she's going to be talking today about incontinence and the pelvic floor. Welcome, Sam. How are you?
I'm good. Thanks for having me back.
Good. So I'll go ahead. You do have an online audience today, along with, I know, a full house in person. So I'm going to go ahead and put your PowerPoint up. If anyone watching from home has any questions for Samantha, please leave them in the chat for us, and we'll have her, she'll address those after the presentation. So you can go ahead and get started, Sam.
All right, as Maya said, I'm Samantha Johnson. I am a physical therapist here at TMC Outpatient Physical Therapy. I've been here for about a year and a half, going on 2 years now, and this is actually my third presentation here for TMC for Seniors. I did one for Women's Health last month called Everything Your Mother Never Told You, and then I also did one for the gentlemen about erectile dysfunction, prostate, and incontinence. So if that sounds like something somebody you love would enjoy, feel free to look those up. They are on our TMC YouTube page. Today I'm going to be talking a little bit more about incontinence in the pelvic floor. I found that my presentation geared a little bit more towards maybe some common bladder dysfunctions that I see a lot in the clinic. So maybe incontinence isn't a misnomer, but we will talk a little bit about that as well. So I always like to start off my presentations with just an anatomy clarification. I think it is so important for us to know what the parts of our body are called, so that as we're trying to describe them to medical providers, we can do so accurately so that everybody is on the same page. The outer genitals of someone that has a vagina is called the vulva. This is what you can see if you are just looking at somebody. The inner canal itself that is often called the birth canal and attaches to the uterus.
Could you speak a little bit louder?
I will try.
Okay.
I will try. If you're having trouble hearing, this pillar is directly in the way, so I'm not sure if you want to try to sit a little bit further on either side and see if that would help. So the canal itself that is internally is called the vagina. Outer genitals, vulva. Inner genitals, vagina. The vagina then connects from the outside of your body internally to the uterus. Directly underneath of your uterus is your bladder, which is kind of what we're talking about today. And this is often why when people are pregnant, they're saying, oh, I feel like my bladder got so small. Well, it's because that uterus there is sitting directly on top of your bladder. All right, so what is the pelvic floor itself? Because that's what I treat, right? The pelvic floor are the muscles that surround the bottom of your pelvis. And I apologize, I usually bring my pelvis with me and I forgot today. They are the muscles that control your bowel, bladder, and your sexual function. So if you're somebody that wants to come in and see me, expect to have questions about all of those different things on your questionnaire, because they all give me an insight into how those muscles themselves are functioning. They have kind of what we call the 5 S's as far as their function. Sphincteric function, so they're kind of your on-off switches for your bowels and your bladder. They're what keep you continent. They act as a support system. They make up the bottom part of your core. A lot of times we think the core is just our abdominal muscles, but in reality, it's our diaphragm, our pelvic floor, our abdominals, and then our back muscles and our butt muscles, and they all work together. They also assist with sexual function, as we talked about. They have what we call a sump pump. They help to keep fluid from sitting in the bottom of your kind of torso area. And then they provide stability for being upright and moving. They assist with posture and breathing as well. So some common complaints I'm getting, and I provided this slide, even though we're talking today about incontinence and bladder issues, I provided this slide just so you know that these are some other things that I do treat. So if the things we talk about today maybe aren't exactly what you're looking for, definitely feel free to still come in and talk to me about these, or if somebody you know has issues with these, have them come in and talk to me. Bladder issues, obviously the incontinence, urinary frequency. Nocturia is one of the things we will talk about today. That's having to go to the bathroom a lot at night. And then painful bladder syndrome or interstitial cystitis. Constipation is another thing as far as bowel issues, fecal incontinence, urgency, pain, hemorrhoids, and then sexual dysfunctions as far as pelvic organ prolapse, dyspareunia, which is pain with intercourse. Vaginal atrophy happens a lot, especially once we get into our postmenopausal phase. And then obviously we all know women who have had babies often have issues that they come in to see me with. So the first topic I wanted to talk about, I've got 3 that we're going to touch on today, is overactive bladder. And I recently got a whole slew of people that had this as their diagnosis, which is kind of what made me say, let's talk about this, because I think this is one that often has a little bit of confusion with it. So OAB is overactive bladder. What is it? It includes symptoms that are a strong and sudden urge to have to rush to the bathroom that's difficult to control. If you can tell me where all the bathrooms are in your grocery stores that you go to, this might be you. If you are going to the bathroom more than 8 times a day, and that's during the daytime hours, then this might be you. More than I also include 10 times just because we live in the desert and we generally drink a lot of water. So 8 to 10 times a day, if you're going more often than that, you might be somebody that wants to come in and talk to me. If you're having some incontinence, UI, if you see that throughout the presentation, is urinary incontinence. That is associated with urgency specifically is often related to overactive bladder. So if you get an urge to go to the bathroom and it's if I don't go right now, it's going to go without me telling it to go, this might be you. And then this also can occur that when your bladder isn't completely full for a variety of reasons. So you go and it feels like, oh my gosh, if I don't go, I'm going to explode. And then you get there and it's like, well, that wasn't worth it. This might be part of it. Contributing factors to why you might have symptoms of overactive bladder, whether it's true overactive bladder or not, are pelvic muscle dysfunction, obviously, or you wouldn't be here. Diabetes can contribute to this. Neurologic dysfunctions like stroke, multiple sclerosis, people that have cognitive changes with dementia or Alzheimer's. Somebody that might have frequent UTIs. It can impact how your pelvic floor muscles function themselves. It often goes into like a painful spasmy cycle. And if those muscles are really tight, they're going to tell you incorrectly that they need to go more often than you actually really do. The hormonal changes that happen with menopause can contribute to this. Again, it impacts how the tissues function, which can have an impact on how the pelvic floor muscles themselves function. An obstruction of the urinary tract, whether that's like a stone or there's a stenosis in your urethra where it's gotten thinner, or even a prolapse where the bladder or the uterus or the rectum has come down, it can kink off the urethra, the tube going from the bladder to the outside of the body. If you just have a hard time moving in general, sometimes it's just hard to get to the bathroom in time, especially if all of a sudden you get an urge that tells you to go now and you're like, well, I'm going to need 5 minutes. Mm-hmm. Certain dietary contributions, and I've got a slide that has some suggestions on this that might be contributing, that can make you feel like you've got to go more often, and same thing with certain medications, especially if you're on a diuretic for retaining fluids or for your blood pressure, that can make you go more often. So normal, and again, this is quotes because normal is a spectrum, is every 2 to 4 hours or somewhere about 5 to 8 times a day. I include 10. And then 0 to 2 times a night. 0 to 1 if you're under 60, and then after 60, they consider up to 2 times a night to be potentially normal. I like to try to get people to as few as possible. Now this slide is more specifically for if you are having some incontinence with your overactive bladder. Here's some strategies to try to decrease the pressure of trying to get to the bathroom in time. Liners or absorbent underwear. Liners can often be really irritating to the vulva, the external genitalia, right? Because they're going to absorb the fluid out of your skin. They're going to make your skin more chapped and irritated. Chapped, irritated skin is not skin that your muscles want to pull on. Think about if I asked you to whistle when your lips are chapped. It's not going to be great. Poison pressa is an internal device that you can insert in the vagina that applies pressure to the urethra to help give you a little bit more control if there's a strength issue. Making sure you drink enough fluids can actually help with your urinary incontinence. And this is because if you are not drinking enough, your urine has become more concentrated, concentrated urine is irritating to the lining of your bladder, and it says, get it out, get it out. And so it's going to tell you to go more often and more urgently. So don't restrict your fluids. That's what I see a lot of times as a common compensation. It generally backfires on you. Smart hygiene, no soap, no scents, cotton underwear. Make sure you're changing your clothes after you exercise. You don't want those athletic fabrics to sit up against your vulva and create potential for infections or irritations. And then come in and see me. Okay, so this list is, I adapted this from a handout that I give my patients. These are common bladder irritants. The top two of the charts that you see are the ones that are more likely to be irritating to your bladder. The ones that are on the left here are most likely to be irritating. The ones on the right might potentially be something that's getting you, and the ones that kind of sadly small chart at the bottom are ones that are actually soothing to the bladder. Now, this is not an elimination diet. I'm not giving you this saying quit eating all of these things, because I'm going to take away all the good things in life if I do that. Instead, what I want you to do is take a couple days, write down everything you're eating or drinking, and then go back and look and say, what things are most commonly on that list? If you want to go above and beyond, you're also going to do a bladder diary to see when you're getting your biggest urges or your biggest leaks. And then see, does that coordinate with when I've just eaten or drank something that is on this list? Try taking it out for a couple days, see if it makes a difference. Add it back in, see if it makes a difference. Then you've got your answer. Don't cut all things out. One more note with that. If you do find that there is something that is irritating, doesn't mean you have to eliminate it. Sometimes just making sure you're drinking more water when you have the irritant, or eating or drinking with something that is soothing to the bladder. Sometimes that's enough to allow you to be able to get away with it. This is an example of a bladder diary, like what I'll have patients fill out. The big key factors are that you're monitoring the time of day that you're eating or drinking, that you're getting an urge, that you are going to the bathroom, or that you're having leaking, to try to start to see some patterns with that. There's oodles of them on the internet. If you come in and see me, I will give you the one that I like to use, but feel free to go ahead and do that. You can even take it into your doc with you, and that'll help them get an idea of what's happening. Okay, so nighttime voiding was the next thing I wanted to talk about. If you remember, the fancy word for that is nocturia. So if you want to knock off your doctor's socks, you come in with that term. What is nocturia? It's waking up at night to empty your bladder. Now, going to the bathroom before you go to sleep and first thing in the morning does not count as nocturia. It needs to be preceded and followed by a period of sleep. So if you wake up at 6 a.m. to empty your bladder, but that's when you're waking up anyways, that's your first void of the day, not one during the night. And this, as we're talking about nocturia, this does not include if you wake up and a little bit of urine has already come out. That's nocturnal enuresis, which is just that, hey, a little bit came out, I didn't tell it to. Maybe you woke up with an urge, maybe you didn't. These are significant to us, obviously, because it's not fun. You don't want to have to deal with waking up. It interrupts your sleep. It keeps you from being as rested. It impacts you during the day. But with higher rates of waking up at night, you also have an increased risk of falls. If you think about trying to get to the bathroom, maybe you're trying to turn on the lights, maybe you're not, maybe you're going from a dark room to a more brightly lit room, that sort of thing. It's actually related to a higher mortality rate. So you don't live as long if you don't sleep as well. I think we know that is true across the board. The research just supports sleeping is super important. And then obviously, like we said, sleep deprivation. And like we talked about with overactive bladder, normal is waking up no more than twice a night. This is a management strategy that I often like to start people with. So if you think about the physics of water, if I pour water out on a, say like on a slide at the playground, where's that water going to go? It's going to go down, right? Water goes to the lowest point. If I am standing up throughout the day and my body is just a meat suit that's filled with water, essentially, where is that water going to sit as it leaks out of my vessels throughout the day? It's going to sit in my legs. The first time during the day for most people that their legs are at a point where they're higher or at least level with the rest of their body is when you go to sleep. So therefore, that is the first time that fluid has a chance to start to come back down out of our legs into our body to be reabsorbed into our circulatory system, where it's then filtered by our kidneys into our bladder. And generally what my people say is, I'm waking up 2 to 3 hours after I go to bed and I have to pee so badly. My bladder is so full. This is why. So this is where I like to start a lot of people. Right before you try to fall asleep. So if you're somebody that likes to watch a little bit of TV for a couple hours before bed, this is right before you're actually going to get serious about falling asleep, not when you first sit down to watch TV. 30 to 45 minutes to start, at or slightly above the level of your heart. So laying on the couch with like your ankles up on the armrest is often a really nice way of doing this, or maybe putting a couple pillows under your lower legs. You can do some ankle pumps where you're pretending you're letting on and off the gas in your car. You can do some thigh and butt squeezes where you're just kind of tightening everything up. And I would start from the feet and work my way up. And lastly, doing some KEGELs. And I'll talk you through what those are in case you need some clarification. And what that does is it starts at the end where the fluid might be sitting most, and it works it all back up in the body a little bit. Our biggest vessels live closer to the middle of our body, and if they're bigger, they have a better ability to reabsorb fluid. So we want to get the fluid as close as we can. Before you try to fall asleep, go to the bathroom. We just did everything to get the fluid out of our legs and where it can be filtered into our body. So make sure you're starting with an empty tank before you try to fall asleep. And if this is successful, you know, because you will be waking up later. Or maybe you won't wake up at all, depending on how much fluid we're talking about here. If this is working, some other strategies you can work on is trying to limit your fluid intake before you go to bed. About 2 hours ahead of bedtime, start to just take some sips of water. If you have medications that you take at night, if they're ones you have to take at night, obviously keep them at night. If they're ones that you could, like maybe they're vitamins, you could take them at a different time in the day, and maybe take them at a different time in the day so that you're not having to use quite as much fluid at the end of the day right before bedtime. And then practice urge suppression. So urge suppression is when I feel the urge to go, instead of dropping everything and running straight to the bathroom, I'm going to be really intentional. I'm going to stop. I'm going to take a couple breaths. I'm going to try not to think about my bladder. Maybe I'll do a couple Kegels, because if I squeeze my pelvic floor muscles, it overrides my bladder. And then once that urge has come back down to a no longer an emergency situation, then I'm going to go to the bathroom. I'm going to repeat that as many times as it needs before my bottom is on that porcelain. All right. Some other management strategies, if you find that nighttime suggestion works well for you, is doing some compression stockings. I found this picture on the internet for the compression stockings, and I really liked them because they have a zipper. How cool is that? You have to be careful because that zipper might create some pressure points. So if you're somebody who has sensitive skin or weak skin, watch out for that. But man, that would make it so much easier. What I don't love about that is her toes are uncovered. So you're going to create this little situation where you might end up still with a little bit of fluid stuck down by the toes. Elevating the legs. This is a bolster really similar to what we use in the clinic when I'm doing my pelvic floor assessments vaginally. And most of my patients wish they could take it home with them because it's really comfortable. Keeping a glass of water by the bed is okay, right? We got to make sure that we're not having dry mouth, especially if you have a medication that makes you have a dry mouth, but try not to drink that whole glass of water every time you're awake. And then sodium limitations, right? If we're eating too much salt, and it can hide in everything. Water follows salt. It's going to force you to retain some more fluids. So that's just something to be aware of, salt as needed, but maybe not as much as you would like. Okay, now this one is kind of a catch-all. It's mostly just pictures, and I just wanted to talk about it because these are some strategies that I have people come in the clinic with that they're using to try to help manage different situations that they're experiencing, but they're really not good for your pelvic floor. So I'm giving you this so you can quit doing them. So if you come in and see me and I ask you if you're doing them, you can go, no, I'm not. All right, so what not to do? Hover when you pee. This is one that everybody argues with me about, unsurprisingly. If you are hovering when you're urinating, you are in a position where you really need, if I'm here, sorry, I told you I wouldn't move. If I'm here this isn't a very comfortable, like I can't hold this for very long. I'm using a lot of muscles to help me stay up, right? So obviously my pelvic floor is going to have to turn on to help stabilize me a little bit with that, which is not what we want if I'm trying to empty my bladder. It's like putting your finger over the end of the hose. Not going to make it smooth sailing. So don't hover, put down as much toilet paper as you need. I know online you can buy like little keychains that have seat covers that you can take with you and then just like flush down the toilet. Cover the seat as much as you need to feel comfortable, but sit your butt on the porcelain. Power peeing or trying to have a race with the person in the stall next to you, don't force the urine out. We don't need to apply any pressure to empty the bladder. The bladder itself has a muscle called your detrusor muscle, and it's not a voluntary muscle. You can't control it. You can't ask it to squeeze tighter, but it gets to a certain point where it stretches enough that it triggers a signal in your brain that tells it to then contract. So it helps to empty your bladder, and your bladder as a whole is a little bit elastic. So it empties like a balloon when you let go of the end of the balloon. It should recoil on its own. It is okay to have a little bit of urine left. Most people have no more than 50 milliliters of urine left in their bladder, and it's still considered an empty bladder. If you push and a few more drops come out, all you did was get rid of a little bit of that residual. Probably not necessary, and I would say arguably the pushing is more detrimental than the leaving the little bit of urine left. Now, if you push and you have like a second bladder empty come out, that's a time to go to a urologist and maybe see what's happening as far as that goes. But try not to strain, try not to push, sit, let it flow. If you sit and you try to let it flow and nothing comes out, that's another thing to come into me for. Don't do your kegels while you're peeing. This is probably one of my biggest pet peeves. If I could scrub this from the internet, first of all, everybody on the internet would want to know what powers I have. Secondly, it's not great. So if you think about the way your pelvic floor and your bladder should function together, they work like a four-way intersection. I can't have two green lights. I can't have two red lights, or traffic is not going to flow, right? So if my bladder muscle, that detrusor, is contracting, I need my pelvic floor to relax to allow it to empty. If it's not a great time for me to pee, or I'm not, I can't go right now, I'm in the middle of Walmart, then maybe I need to have my pelvic floor contract more, and that helps to override that detrusor muscle so that your bladder can keep filling and you don't have to run to the bathroom. So don't do your kegels while you're peeing, because you're going to train your body to do bad things, and it's going to confuse that whole system. Okay, so those are the topics I wanted to discuss today. If this sounds like something that is of interest to you, that you would like to come in and see me, or for my people that are virtual, if you're not in Tucson, you want to go see another pelvic floor PT, what are the things that that'll include? Everybody does it a little bit different as far as exactly how we want to do it. I have a very orthopedic background, so I tend to look very globally with my patients. The pelvic floor assessment itself is not required by any stretch of the imagination. However, I would argue that if you came into me with neck pain and all I did was look at your low back, you might be a little unhappy with that, because I didn't see what was going on with the neck. So if I can't assess your pelvic floor, I can't tell you exactly what's happening with it. We might be able to control some symptoms, but it's not going to be as complete as it could have been. I treat this like a buffet. I like to give my patients the option on what they would like to start with and which direction they'd like to go to begin with. They can be done in almost any order. I have a few things that I'd like to do it in a certain order, just because if I don't, then I might miss something. But generally, if one day you come in and you're like, I really would like to keep my pants on today, that's fine. We can do that. The pelvic floor assessment itself. I love my gynecologist. She's fantastic, but I try to make your experience different than going to the gynecologist. We don't have stirrups. You saw that bolster in that picture? That's what I used. Your legs get to go up on that. We like to get you as relaxed as possible. I don't use a speculum. I don't visually need to see what's happening in your vaginal canal. At most, I might spread labia and apply a little bit of pressure when we do the prolapse assessment. I'm starting with a visual observation of your perineum, make sure everything looks healthy and happy in the way it's supposed to. I'm touching the muscles starting externally, moving our way internally. There's 3 layers to your pelvic floor, so we've got to hit all 3. And then if I'm not finding any muscles that are really short, really tight, and we can't figure out how to get them to let go, then we might talk about Kegels. Kegels, of course, being that pelvic floor contraction that I think most of us know we're supposed to do, but nobody actually really told us how to do it. I'm going to be the person that tells you that. It will also include a lumbopelvic or a core assessment. This is how you're moving in space. We're looking at posture. We're looking at strength. We're looking at stability. We're looking at how you're breathing. We're looking at all of the muscles that surround and attach to the pelvis, of which there are about 36 that can impact how the pelvic floor functions, directly and indirectly. What sort of treatments are we going to do? What does this look like? Well, if you've ever been to physical therapy for like a joint replacement or for back pain, it's going to be really similar. If you boil it down to the essence, we're doing the same things. We're doing some manual work. We're teaching you some exercises. They just look a little bit differently because the muscles that we're using that we're working on are a little bit different. There's no joint that they're controlling, so it's a little hard to see what's happening sometimes. So we'll do some manual techniques working on muscles and other tissues as needed. We'll do exercises for strength, endurance, and coordination. Not all Kegels are created the same. I'm going to teach you the right ones based on what I find with your muscle function. We're going to work on some stretching of the legs, of the back, of the shoulders. Some exercises that I really like to give people as far as strengthening the muscles around the pelvis are clamshells, bridges, and pelvic tilts. I'm very particular about how I have people do them. If you know anybody that's worked with me, they probably mentioned that. We're going to talk about breathing mechanics because the pelvic floor and the diaphragm work together like a piston. We might use some biofeedback. Biofeedback just means that I am using something to give you information about your body. We can do that either with me touching you, or we can do that with a computer. The way we do it in this clinic is with external electrodes. They go on either side of the anal opening, and then it connects to the computer so you can see on a graph your muscle activation. It's kind of cool. And then we talked about the body mechanics, the posture, lots of education. Bring in a folder with you. I am the queen of handouts. Okay, and then how to do a Kegel. So these are some different verbal cues that I like to use with my patients. What I am looking for is the thing that gives us the most symmetric contraction. Now, visually, I'm observing that and saying, was that contraction mostly around your anus, or was it more towards the front around your vagina and your urethra? I want it to be kind of towards the center, or if you're having one issue over the other, we might choose a different cue based on that. But in general, ones that work well is closing your vagina. And also, as you're all sitting here, you're all going to try this. I know you are. You don't have to admit it. I shouldn't see anybody move. If you go up in the air a little bit, it means you use your butt cheeks instead. That is not a Kegel. If your legs squeeze together, that is not a Kegel. We want this to be something that you can do it. Nobody else knows you're doing it. You can think about closing your vagina. A lot of times I say close your vagina and pull it up to your nose. And that should give you a good sense of lift because that's what these muscles do when they contract. Maybe you're squeezing like you're trying not to pee, or like you're in a crowded elevator and you're trying not to pass gas. That one works really well for people. And these are, again, this is where I wish I brought my model. These are bowl-shaped muscles. They should create a sense of lift if you have enough strength. They are not always going to create a sense of lift if you don't have enough strength, but that's okay. That's why you're going to come in and see me, and we're going to work on that. Strength is not the end-all, be-all for pelvic floor function. Again, please don't stop and start the flow of your urine unless you absolutely cannot find your pelvic floor muscles. I would argue instead what you might want to do is put your hands on the outside of your vulva, or even if you're comfortable with it, put one finger inside of your vagina and see if you can feel that squeeze. That's a better way to start. It helps your brain connect because we generally have better sensation and connection with our hands. But if you aren't comfortable with those things or you still can't figure it out, it's okay to do it a little until you can stop the urine, and then don't do it again. Okay, how long does PT take? It depends. That's our favorite answer in physical therapy is it depends. It depends on your history of surgeries. It depends on the severity and duration of your symptoms. If you've been having symptoms for 10 years, sometimes it resolves quickly, depending on what else is going on. But very often it takes a little while to resolve. Your stress levels, your general health and activity. I sometimes have my coworkers who will say, hey, I think so-and-so would really benefit from seeing you, but we're working on just them being able to get up out of a chair. And I say, you keep them until you guys can do that, because it's not gonna matter what I do if they can't get to the bathroom on their own or fast enough. And your compliance with homework. I'm a really big advocate of, I want to make you your own best therapist. I want to make it so that you don't have to come in and see me again. Obviously, you're welcome to if you need to, but as much as I enjoy working with you all, I don't want you to have to come back. I typically schedule, and this is where all PTs are a little bit different, but in general, we're seeing people about once a week over a longer duration. These muscles are hard to train for a lot of people. We can't see what they're doing. We're not super connected with them for a variety of reasons. So sometimes it can take a little bit of time. But it's what you do at home that makes the biggest difference, which is why I give a lot of homework and I space things out so that you have plenty of time to work on the things I give you before we try to add new things into what you're doing. There's a look in the eye that people get when they're hit their overwhelm points. It kind of glazes over deer in the headlights. And so usually we stop for the day at that point, and then next time you come in, we'll add new things. Generally with bladder, as long as there's not a neurologic condition that's occurring and there's not just like a complicated presentation of like a lot of bowel symptoms as well as maybe sexual dysfunction, just like a broad variety of symptoms. Generally, my patients are starting to notice some changes by the earliest, the second visit. Sometimes people come in and say, I think I'm starting to see a difference. Generally within the first couple weeks, people are starting to say, oh, hey, yeah, it might not be consistent, but I am seeing like I can create a change. And that's perfect. I did have a patient come in one time that felt like she should be an easy fix because she had so many things going on, and that's just not how it works, unfortunately. How do you get in to see me? Again, these are for people in Tucson or who winter here in Tucson. We do require a referral to be seen. Most hospital-based clinics do. You can get a referral from pretty much anybody except for your dentist or your chiropractor. So primary care, gynecologist, urologist, gastroenterologist, we get a lot from our colleagues at Pain Management that is right next to us. Any of those people would be able to give you a referral to come over. They don't have to say me. Right now, I'm the only pelvic floor PT we have at TMC. We do have plans to hopefully take on somebody else soon, but that's down the road a little bit. The referral can be faxed to the phone or to the fax number that you see on here. If your provider is within the TMC network, they might be able to just send it within the internal network that way without having to fax. Our clinic phone number is listed at the bottom. If you have any questions about coming in to see me with insurance or scheduling or did they get my referral, you're going to call that number. If you have a question about, well, I'm not sure if I'm appropriate for physical therapy and I'd like to talk to Sam, call that phone number and they'll send it to me and you can leave a voicemail and I'll call you back when I can. I love to talk to people about this and see if you benefit from coming to see me, more than likely. But definitely feel free to call. And then these are some of where I got pictures and informations and that sort of thing. The pictures are, they are Pelvic Guru's pictures. I have permission to use them. And then that is all as far as my presentation.
So thank you so much, Sam. That was great. You really covered a lot of information that I know affects so many people. I do have a couple of questions that came in that I wanted to ask you. One was, what tips do you have to try to resist the urge to go when you're lying in bed at night and all you are focused on is having to go one more time?
Yes.
Is there a type of meditation that might work to help with that, or?
So there are some medications. As a physical therapist, I tend to gear on the side of let's try to avoid adding more medications if we can, just because they usually have side effects associated with them. A big one of which is often constipation, which can create more pelvic floor issues. Some common medications that people are, and I wrote these down because I forgot to do it on a slide. And I knew somebody was going to ask. Some common medications are tiltaridine, which is Detrol, oxybutynin, and Myrbetriq are the three big ones I see. They like I said, they're often associated with some other side effects that can make life a little bit more miserable. So the urge suppression that I kind of went through a little bit in one of the slides is still appropriate at night. You want to do it before you get out of bed. Maybe sitting on the edge of the bed is the best place because the pressure of the bed up against your perineum or the vulva as you're sitting on it will actually give you better control. Think of little kids as they're learning potty training and they hold themselves. That little extra pressure gives you a little better control. So you're going to sit there, you're going to stop what you're doing, you're going to take a couple deep breaths, you're going to maybe do a couple squeezes, you're going to try to think about what you've got coming up the next day you're really excited about, and then when things are back under control a little bit, then you're going to go ahead and go. But if you get up and you try to do this while you're in transit, it's not going to be super successful. And I generally also recommend people, at least as you're getting used to the urge suppression, don't wait until the urge comes back. Once that first urge is under control, go ahead and go. And so you know you can control it, because if you wait till the second urge comes back, it comes back with a vengeance and is even harder to control. That generally doesn't work well for people at night or during the day. But nighttime urgency is really hard to manage because you don't have anything else to think about except for the fact you can't sleep because your bladder says it has to go.
Sam, are there any types of meditation that would help with that when you're at night? You know, not medication, but meditation as well?
Meditation?
Meditation.
I'm sorry, you're saying medication like medicine?
No, meditation.
Meditation. I mean, it can. I think a lot of people find meditation hard to do, especially if you've got something that's like really urgent looming in the back of your head. But yeah, if meditation instead of sidetracking works well, go for it. Okay.
And can you fix a UI problem with PT, but then have it start again at a later date?
For sure. I see that happen quite a bit when there's functional changes. I saw this a lot at the beginning of the pandemic when people either became more active or less active, depending on how it impacted them. If you have a change in function, like maybe you go through a surgery and you're not able to be up and moving for a while and you lose some of your functional strength, then that might make it so that your pelvic floor has to pick up the slack, which maybe we got it strong enough and functioning well enough to manage where you were at the time, and then it no longer is enough at that point. I do find a lot of the times just getting back to basics and starting back over at being really consistent with doing exercises is enough to get you back to where you need to be without necessarily having to come in. But sometimes people come back in to see me again at a later date, and we just do a couple of visits to update them on where they need to be now.
Okay. And, you know, leaking and exercise, I know that is a huge issue. Jumping jacks, it doesn't matter, right? When you're just jumping around. What tips would you have for that?
Oh man, Maya, that could be a whole presentation. So the way I like to describe it is you have to think of the way the bladder and the body are working is a series of pressures. If my bladder, and I'm just going to use an arbitrary number system here because I forget the units for pressure. Somebody in physics is going to yell at me for that. So if my bladder has like a 5 amount of pressure in it, but my pelvic floor only has enough strength for a 6 amount of pressure, my bladder can only fill to 6 before I'm running the risk of having more pressure in my bladder than my pelvic floor can control. Now, if I add jumping jacks or running on top of that, and my bladder is kind of full, I've got more pressure in the bladder again. So my pelvic floor has to be able to provide even more pressure to counter that.
Okay. Yes. So, I know I used to do a lot of jumping, not jumping jacks, but jump rope.
Yeah.
And jump rope, it took a long time before, you know, half of us wouldn't have to be running out to.
Yeah. I always recommend class. Yeah. I always recommend before anything that could even be construed as exercise, like when I'm going out to dig, like this weekend, I dug a really big rain basin in my yard. I made sure I emptied my bladder before I did that because I don't care how strong your pelvic floor is. If your bladder's full and you're digging, you're going to run a risk. So anytime you're going to be doing something that might force more pressure down on your bladder, empty your bladder ahead of time so that you don't have to deal with it. I think that's just good bladder habits, is to go ahead and go before you have an activity. Don't do that regularly. That's another thing. Everything is with a caveat, right? But doing, smart about if I know there's a really high likelihood I might have a leak, go ahead and go. Try to minimize that so you're not stressing about it. Because if you're stressing about it, your pelvic floor is going to tighten up, which is going to make it more likely to happen. And then the knowledge that Kegels, and we didn't talk about this presentation. I think I talked about this in my first presentation last year. But Kegels are not the end all be all for pelvic floor function. Because if I am somebody that has a really tight pelvic floor, this is my pelvic floor I use in the clinic. If I have a really tight pelvic floor and my muscle is kind of stuck, so my people behind the column can see me, and it's stuck in this position, and I try to tighten it up more with Kegels, I'm actually not doing anything to get myself better function here. I need to be able to lengthen that muscle so that then when I go to contract it, it's got a bigger range of motion, it's stronger. Short, tight muscles are not strong muscles. They've got to be able to relax. So the relaxation, in my opinion, is just as, if not more important than the contraction the vast majority of the time.
Great. So I just want to put up, I don't have any other questions that came in, but I do want to go ahead and just one more time, if somebody was interested in seeing you in the clinic, I put the phone number up for our TMC Adult Outpatient Therapies. It's 520-324-7005. I want to thank you so much for being here today. I'm going to turn this back over. I know we're talking about doing another talk down the road, which I think people are going to be very interested in as well. So hopefully in the fall we'll have you back because there's a lot we can sort of unpack on these topics. So thank you so much
talking about them. So
all right, thank you again.
Thanks, Maya.
Thanks for being here today. Our next talk is going to be about arthritis, signs, symptoms, and treatment. We'll have that on Wednesday, May 10th at 2 p.m. If you're interested in watching this class, please give us a call in the office at 520-324-1960. We'll see you soon. Thanks.